So good afternoon, everyone. We are delighted to be here today to host the first webinar of the series, Transforming Health Services, examining the new government's priority and what they mean for innovators and healthcare professionals. So before we start, a few words about us. So we are part of Unity Insight, a social enterprise that used to be the analytics and evaluation function of health innovation Cancer Sussex. And this means that we have a vast experience working with healthcare professionals, innovators, and commissioners to support them with NHS-specific challenges. And we offer analytics and evaluation services mainly. My name is Léa Quentin. I'm a lead analyst, and a lot of my work is around real-world evaluation with a bit more of a focus on digital and AI technology. And I'll pass on to my colleague Pete to introduce himself.
Yep. Hello, everybody. My name's Pete. I'm a senior analyst on the team here. Got, as with Léa, quite a lot of experience across real-world evaluations of mixed method delivery. In terms of clinical areas, tended to work in particular around stroke services, mental health services, social care, and as we'll be covering today, a fair amount of work relating to system transformation and systems thinking.
Thank you, Pete. So I think in any given week, we can all think about several news stories about the NHS. Some positive about treatment or drug discoveries, and some less positive, maybe about performance, social action, government, maybe all three together. So considering how omnipresent the news, how omnipresent the health services are in the news, it can be quite difficult to distinguish between attention-grabbing headlines and meaningful change in strategy or service delivery. And this is what we will cover today by going through an overview of challenges of the NHS and the ambition, and then looking at the particular priority that we're looking at today, getting the NHS back on its feet, through two case studies, one around the workforce and one around service transformation. And we'll finish with some key takeaways and time for questions as well. So having a look at the ambition and having a look at the challenges and the ambitions, the Health Foundation reported on 9 major challenges faced on the health and care in England. And these are diverse, but they include growing health needs linked to an aging population with more health long-term condition and widening health inequality, high unmet needs driven by underinvestment and staff shortages, as well as a fragmented picture between health and social care. So these themes are for England, but a lot of these also apply to other UK nations. And this is particularly relevant as the Department of Health and Social Care have commissioned a new independent investigation on NHS performance, which we'll report later in the month. And we'll update some of these challenges and performance indicators. And to illustrate some of the themes that we've just covered and the challenges, here's an illustration. So it's a graph of the waiting time for consultant-led elective care between August 2007 and February this year. And we can see a picture of growing number of patients waiting to receive care, as well as a longer waiting time. And that's really a long-term trend, but it has been accelerated by COVID. And we can also note some progress made for other metrics, and not on this graph, but in terms of more just other reporting when it comes to referral to treatment data. However, that's not always the full picture, but that's just a bit of a positive note as well on that particular challenge. So against this backlog of a well-documented challenge, we also have a complex policy landscape showing healthcare priorities and strategic changes. And here are some of the key documents produced in the last year, from the long-term plan to various post-COVID-19 recovery policies. And these documents collectively really aim to improve quality, accessibility, and also integration of healthcare services. And so, aware of the challenges ahead and the strategic vision for the NHS, the government set up the following priority in his manifesto. They include many things, but today we will focus on one particular priority, which is getting the NHS back on its feet. So what does this mean? So this is broken down in two key objectives, so reducing the record waiting list and meeting the 18 weeks referral to treatment target. And this will be done by delivering an additional 2 million NHS operations scan and appointment, getting neighbouring hospitals to pool resources to create shared waiting lists, using scarce capacity from the sector, the independent sector, ending the workforce crisis in both health and social care, and then having an ability to reset relations with NHS staff. And this mission statement focuses on enabling more NHS activity by increasing capacity using the levers we've just covered. So what does this mean for innovators of healthcare professional? I think this really prompts to examine the work that you're doing, your innovation, your intervention, to determine if it addresses any of these themes, whether that is increasing NHS activity, enabling integrated care, using third-party or private sector, supporting workforce planning, or avoiding service disruption. And if you do, there will be value in evidencing how your solution aligns with the government agenda. And this is what we will cover in the rest of this workshop. How can you demonstrate that your innovation or intervention addresses this priority? And we'll look at a few case studies of evaluation and how they've done this. So the first one will be around impact on the workforce. So this is an important one to consider, as it is really key and central to that getting the NHS back on its big priority. And it's likely to be relevant for a lot of intervention or innovation, whether they aim to improve service delivery, improve staff satisfaction, create capacity. So all of that is really closely linked to the workforce. Our case study is around the evaluation and looking at the potential impact of free workforce programme. There was a regional focus, so covering Kent, Sussex, Wessex and Oxford. And we were primarily looking at economic impact, so a bit of a in-year analysis. And the three programs of interest were Sleepio, so an online cognitive behaviour therapy for insomnia platform, S12, which is a solution that assists approved mental health professionals, and S12 GPs when it comes to Mental Health Act paperwork and assessment, and finally EDR, so an electronic repeat prescription, an electronic repeat dispensing. And so what we looked at with this work, so the way we would usually start would be to really determine the potential benefit associated with the program, research what sort of data is available to monetize the benefit, collect that data, and then put together the analysis and the results. Due to the project constraint and also the time it was collected at, we had to shift that approach quite a bit to what was achievable within the time, what we could collect in terms of metrics, how can we supplement that, and finally to do the analysis and still monetize the benefit. So a first really big learning with the case studies is just to take that time to really assess potential benefit beforehand, so that you can really have the most robust metrics to collect and evidence the impact of your intervention or your innovation. And so a lot of benefits were evidenced across the free program, and quite a few of them were linked to the workforce, such as staff time released for different roles, a reduction in staff absence, reduction in time to process forms of more admin time. And so looking back at the government priority, our recommendation for interventions or innovation looking to show impact on the workforce would be as follows. So really keep in mind that the workforce benefit can be many and far-reaching. So go beyond just the time release for the staff. Think about how benefits on the workforce can impact patient income, how they can facilitate system change and culture change as well. The other element would be to design your comparative data early and to acknowledge limitation in current reporting, and work with local team to use existing data. So really try and maximize what you can do with that data. And that's especially important if using metrics that are quite are very multifactorial, as it might be hard to really claim attribution if they're not designed properly and robustly. Another recommendation would be around thinking about qualitative analysis to add depth and nuances to your impact reporting. And then finally, to link up with regional NHS workforce training and education teams, so formerly Health Education England, to leverage local intelligence on your workforce. And I will now pass on to Pete to talk us through the next case study.
Thanks, Leah. Yeah. So as we talk about the different challenges in meeting the government's ambitions, one of the key things that we wanted to talk about today was systems thinking as well. If we go on to the first slide, obviously our role generally comes in the position of evaluating change, and that could be in any different form or focus on any different area as well. Quite often the work that we're asked to take part in is quite focused. So as you'll see on the right hand side, those first two levels either we'll be looking at will an intervention or a change in a service affect the quality of care that patients receive, so how effective that the treatment or whatever it may be would be, or how effective it is in aiding prevention of either deterioration or just occurrence in different scenarios. Or we'll be looking at things from a service perspective and thinking about whether a change makes a service more efficient, can create savings, can create or release pressure within a service as well. And also, obviously, quite a large part of our work relates to health economics as well, the budget impact for that service, but fairly localized and zoned in evaluation services that have a really important place in the development and delivery of change, but don't always take a full view, in particular when we're looking at the reality of meeting such a large politically laid out priority of helping create more capacity and get the most out of the workforce within the NHS. No single service, no single organisation exists in a vacuum within the NHS. Everything being interrelated has to kind of be taken into account when considering delivering of changes. And that's when it kind of comes onto these second two layers. Social impact, which I mentioned first because we do actually incorporate that into a lot of our health economic work where the evidence base exists, which may be the knock-on impacts in terms of population health, or even something as simple as time savings and reduction in care demand for individuals out in the community. And obviously increasing area of focus being the environment as well, with particular forms of evaluation focusing on meeting the net zero targets, life cycle analyses and things like that. But one of the main gaps generally is what affects the system level. What has the impact upon the system itself, and whether that means a single service within a wider pathway or a single organization or across multiple organizations. So if we go on to the next slide, please, Len. There are kind of two key things that I wanted to draw out in respect to this that hopefully is useful, because thinking about systems thinking as a concept in itself, the main thing is that focus upon relationships. What are the relationships that make the system work? What are the dependencies for an individual service, whether that may be diagnostics or triage services before a treatment pathway, or even just more focused in analysis around demand for different services. The referral pathways, where they're coming from. Are they coming across from different departments within a hospital or within a single organization, which may happen within surgical pathways? Or is it primary to secondary or community care? Now, how do those pathways actually operate? And analyzing those and making sure those are truly understood can make a huge difference to the delivery of a change within one single part of that pathway. Understanding the treatment routes, again, very similar to the referral pathways. Where do patients come from? Where will they go once the treatment is being delivered? And obviously that leads on to the kind of post-care recuperation rehab side of things as well. Systems thinking, the actual delivery of change could happen anywhere along that pathway, but it's still part of the whole piece. And if you're going to introduce changes that may require buy-in from across that pathway, all the different organizations involved within it, I think designing evaluations that can actually highlight and show that value right along the whole system is key to delivering that and creating sustainable and scalable change. The other thing, obviously, is within systems thinking is thinking of the resources that are needed within the service to make it work. So those conditions, the travel times in terms of how practical it is for patients to get to a location for a service, the workforce and resources within it, and the waiting lists that may hold up or prevent treatments being provided potentially at the optimal time, and the long-term impacts of that. There's another angle as well, which I haven't got covered in this slide directly, which is looking at this not just across multiple organizations, but looking at it within a single organization as well. And sometimes there's very interesting changes that can happen just from changing one of these elements I've listed around resources, workforce, even just the placement of the resources that the workforce need to be able to do their job effectively. There's a resource which we can provide the link for, called the Journal of Improvement Science, which has a really good number of case studies around this and changes that they've delivered within chemotherapy services and things like that. We're arranging where the patients sit effectively can have a huge impact on the actual delivery and help recover a number of services, which in some of those examples were in real positions of crisis at points in the past, but they've been able to work through it because they've taken a systems thinking and a design-led approach to how they're going to deliver the change that they want to deliver. Thank you. The autoplay on the right-hand side there. One of the key tools that we use around systems thinking is system dynamics modeling. This is a technique developed in America, and it's still relatively new, but it's about really tracing and looking at the factors and the causal links and how they all link up across the system to create a framework that then you can measure change through. So on the right-hand side, this little diagram is basically a flow of patients from left to right, broadly, with a number of different factors feeding into various decision points that drive patients along the way. So using real-world data, plugging into this to look at how likely a patient is to be eligible for a certain treatment, and then they would then be diverted into that pathway along this model. The real benefit of this is that it's a very flexible tool, but also that it can be drafted and iterated upon very actively, it creates a framework where any of the inputs can be edited and you will see the resulting output. So if you get a model which is working pretty much reflective of the real world situation, you can introduce your change and then you can see the impact at the end of it based on the real world probabilities and the real world activities across that pathway. It's a useful tool for, as we've said, modeling relationships across that system, and how those changes will influence the system and the outcomes that will be seen across that. And obviously those outcomes can take any different perspective as well, whether it's impact upon the treatments and the likelihood of delivering the right treatments at the right time, or if it's a matter of creating that space, reducing the waiting lists and increasing capacity, and seeing how introducing slightly more resource within a certain step of the pathway may release that pressure right across the whole system. So to look at this in a bit more detail, as I've mentioned already, it's about representing complex systems and looking at the relationships within them. Broadly speaking, it works in one of the ways that you may hear about it being referred to would be stock and flow modeling. And on the right-hand side, I've taken this visualization, which I've grabbed from an NHS England page, which I've got linked on within these slides as well, which looks at actually using system dynamics approaches to look at system level demand, capacity planning, And there's even an example waiting list model in there, which you can go and calibrate and change and figure out the benefits of using such a model and being hands-on with it. It's all about the variables, so it's different factors that affect demand, which goes into the referrals in side of this, the inflow on the right-hand side, and then passing into the stock, which is where patients would be held waiting for however long on average they would wait before they get seen, and then the discharge back out of the service at the other side. So with obviously some of those patients may need to be seen again, so there's feedback loops and other elements which you also would consider, and those are kind of all those causal elements that I've mentioned, that impacts not just demand, but also sometimes just the backlog of cases and how quickly they can be seen, particularly when you've got situations with much higher urgency cases that sometimes hold people back further along. So mentioned the different uses of those variables and how this builds up a framework that can be adapted quite quickly and flexibly. But it's also a very useful tool for developing a pathway and then being able to take it and essentially airdrop the data for a different area or a different service. And using the existing framework, you can then see how that applies to a different population. You can get some quite interestingly different results, which are just based either around geographical, population, demographic factors, that when you look at things in terms of the nuts and bolts of how a system is working, you can recognize how that may need to be adapted to help meet the needs of another area. So yeah, widely used as a problem-solving tool across disciplines and across many different sectors within society. Engineering in particular makes great use of this. But that's my brief overview of system dynamics modeling, which hopefully gives people some food for thought in terms of a good approach for looking at demonstrating the value of a change and how it doesn't just affect the service, the direct service that the change is happening within, but also all of those further relationships beyond that. So we're going to run through a quick example of how we've used this in the past as well. So we've recently completed a project which looked at the transformation of community mental health services within an ICS. To help around this, the change itself was the introduction of a range of different services within the broader community mental health space, designed at increasing access for patients that could not previously access specialized care along the way, and to help evidence this change in the way and how it had helped meet needs that existed within society that weren't previously being met by the traditional model of care, and therefore led to people having to manage their own conditions and with a larger than necessary number of people having their conditions deteriorate over time until they actually did meet that point that they could then be referred into a specialized clinical service. But obviously at that stage, their needs being that much greater, the intention is to increase the access of people so that people could be met earlier, prevent deterioration, and therefore release the pressure within the system as well that occurs because of that unmet need. Okay, if we go to the next slide, please. So to do this, we built the model around the observation of referral patterns. So looking at the demands that were coming into the system, into the community mental health space, and where they were going. And then we introduced each of the different service lines, which are these SL1s. So to explain this visualization a bit more closely, first of all, we have a number of different routes that people took to come into into community mental health services. Obviously, the vast majority of people coming through primary care, and a key point being that where services didn't exist that could take these patients on, they generally stayed in primary care, where obviously general practitioners and other services within primary care space were not equipped to always meet the needs of people with developing eating disorders, for instance. It's a very technical area of delivering therapy. It can be quite sensitive and obviously covers an enormous number of quite individual situations, and GPs often will not have the skills within their organization to help deliver upon those needs. The introduction of services that didn't require things to develop to the point of a formal diagnosis helped take that pressure out of primary care. So that's where this SL1, 6, 7, and 8 in this middle area, this is what this represents. It's covering a much broader range of patient needs than just eating disorders, but these were in place to take patients from primary care, secondary care, and also patients who were just looking for help themselves and looking for where they could go, introducing the options for them to be able to get some specialized care, understand their conditions more, understand various strategies and techniques to help manage their conditions in the short term and short to mid-term. And as you can see off the back of that, the very top line is really key because that represents just pretty much direct release of pressure within the system. These aren't patients that are having to be bounced between services. They aren't patients that are having a frustrating time being taken seriously. They have spoken to someone who has expertise. They have been directed in the right way to get further help if needed, and have been able to be discharged out of this process again. And they can always rejoin at a later date. That's part of the design of this in this particular case. A large group which did require ongoing treatment. However, this often related to further referrals into various other services as well. So it was linking up all these different services, third sector organizations, and a wide range of different services across the community space to help manage those ones that needed ongoing treatment, and also further referral within the actual community mental health model itself as well, which are these other service lines that were introduced. Overall, it was a really interesting project, and it did help demonstrate through the system dynamics model itself, as well as further analysis that was facilitated by the fact we'd gone through the system dynamics process. We could help demonstrate how they had met a significant amount of unmet need, and it was showing a large release of pressure within primary care and some of the other services feeding into it as well. And it's something that, if we just looked at it in terms of the impact within the community mental health space itself, the project may have appeared as just new services doing more things for people who weren't previously present within the system of services that had existed beforehand. And demonstrating the value of that kind of transformation is quite difficult when you are just looking at things that are generating new processes, new treatments, new services having to be put together, which are obviously quite expensive, and being able to show that it is actually supporting the wider infrastructure of the healthcare service was a really important story to tell. If we go on again, please, Leah. I think I'm waffling a bit now. I need to push on. So we've got a couple more examples I was going to briefly mention. We've also performed a few other system dynamics models which cover different scenarios, one of which being an observational model which looked at primarily the conveyance of patients into the system and the decision-making process of where should the services that have the expertise to treat those patients, where should those be placed? And so there were a range of different options, and we developed a model which showed an awful lot of different consequences of the different decisions around: would patients get there in time to have the most benefit from their treatment? Would patients be able to be referred on if needed? How would it affect the travel times? Would it also maintain the right level of service so that you could retain the skills within the organization as well? So it's quite an interesting model that looked at, you built the framework of how do these systems work and what are the decisions being made within the ambulance service around conveyance, but then being able to build that framework and then test a range of different scenarios based on that to inform the commissioning decisions at an early stage before going into consultations and all sorts of processes that needed to follow. The other example I wanted to mention was really focusing around triage and how system dynamics can help in showing that having the right decision making at the front of the pathway can have a huge impact on the very end. We've been looking at triage and diagnostic tools which have a major impact upon endoscopic demand. and which is an area which within hospitals has a significant waiting list and waiting time for patients, and being able to effectively look at some of those lower risk examples and not endlessly, not just have them all fitting into the same pipeline, but being able to risk manage effectively, obviously releases that pressure within the acute services. I saw there was a question. I'm coming to the end of this bit, so let's have a quick second.
Sorry, that's just me. Just
cool.
carry
on. So there's I've run through quite a few different examples. There's a great number of there's a really useful resource that I was going to also mention, which is an organization, not a company, an organization called Whole System Partnership, which is a non-profit that looks at specifically within healthcare, talking through systems thinking and system dynamics in particular. So I'd recommend looking that up if anyone is interested. There's a range of different benefits and applications across these tools, and how system thinking can help provide that clear evidence that supports complex decision making. It allows you to test designs digitally prior to implementation, hopefully saving time and resources in the long run. Develop best practice and appropriately position innovations within the clinical pathways. So where will the change best fit? Support planning and implementation strategies, and obviously the key one, demonstrating the value at a whole system level, encouraging collaborative improvement activity and input. Okay. On to the next slide, please. There. Or have I clicked in? And there we go.
I think that is the next slide. But...
sorry, next one, key takeaways. Thank you. Yeah, so looking across everything that we've talked about, obviously a lot of this is around how to best meet the various challenges that exist within the NHS today and design change that can have the most impact and meet the government priorities around reducing waiting times, upskilling the workforce in order to help the NHS be robust enough to meet the rising pressure within the country. A lot of this is about designing evaluation work and measurement strategies that can work across the entire life cycle of changes. Identifying the right evidence within the early stage, which can be a process that could go right into thinking about the intended use of an innovation, the impacts that you'd hope it would have, and again, what needs to take place, where should it be introduced as well, as I've just mentioned. So processes of logic modeling, for instance, can really help with this. That can also help outline attribution issues as well. What evidence is available and how do we know that it's evidence that the change is having the impact that we hope it would, particularly if some of the measures are multifactorial, we mentioned there. So where there's A&E visits and admissions, there's all sorts of different causal elements that feed into that. It's important as well to think about the available data and whether any further evidence generation is needed to be able to show the impact that you'd hope you'd have. Well, the quality of insights fully depends on that quality of data that's available. And by identifying the gaps and limitations, those could be filled out, completed, and then hopefully create a much stronger message at the end of the work as well. And yeah, the systems elements, which I think I've gone through quite fully, around using system dynamics modeling and things, and also the importance of socializing the findings, finding a message that's clear enough that can be shared both across the healthcare services, but also out into the wider population as well, so people can understand the changes that are happening, the reasons why they're being introduced, and what they should see as a result of it as well. Blair, did you have anything to add on that?
No, I think you covered the key takeaway really well. Thank you. We do have a couple of minutes left if there's any question that the attendees would like to put through the chat. But as you think about a question, we would just like to thank you for attending, and also to remind everyone that this is the first of a series of workshops that we'll be holding between now and Christmas, looking at NHS priorities and how they are relevant to healthcare professional innovators, commissioners, and providers. So feel free to have a look at the other ones, which one are relevant to your work, and join us for the next sessions.